Hi, have you ever had trouble figuring out what a pneumothorax is or hemothorax is and you're struggling through school if you're taking EMS, that thing? I'm Jason Jolson. This is,
Jay Davis.
today we're going to talk about the hemothorax and the pneumothorax. And we're going to go over a bit about the respiratory system, but hopefully you already have an understanding of that.
I think we should have called this Finding Pneumo.
Well, that would be like fantastic.
Yeah.
And then we have finding hemo.
But then what would we do once we found them?
Well, we'd have to probably fix them,
I think so.
right? Do something for them. So, anyways, I'm Jason Jolson. I'm a clinical educator. I've been a paramedic, advanced care paramedic in Alberta for over 30 years. And you?
Yeah. So, Jay Davis, I have worked in EMS for way too long. I have a PhD in physiology, which makes me one of the nerdiest people you'll probably ever meet. And I also used to work in transplant medicine.
All right, so we're going to just jump right into it. And in the next section here, we're going to talk about the overview and what a hemothorax is and a pneumothorax is.
All right, so welcome to our lecture. This is a BLS level hemo and pneumothorax lecture, subtitled Two Sides, Five Lobes. Gigantic, huge pain in the ass. So, starting off, quick little caveat. The purpose of this lecture is not to discuss lung anatomy or physiology. However, I would love to do that. That initial level of knowledge we believe you kind of have innately right now. If you want us to talk about it in a different lecture, we would love to. So we are holding the assumption that you do have a novice level of understanding on pulmonary function. And like I said, if you want us to talk about that in a different lecture, we will. However, if you do not have that, this lecture may not make sense to you. So we're going to talk about the lungs. Why are they important? Why do we have them? And simply enough, perfusion. We love perfusion. No perfusion, no life. And the way humans perfuse is largely with the cardiopulmonary system. So we love lungs, we love heart, life is great. Now, we've all learned about Boyle's Law, and we all dreaded having to do math for Boyle's Law. But it's incredibly important. It's an inverse law, which means that as one thing increases, the other thing decreases. And what are those things, Jay? It is all about.
We're talking about the lungs, aren't we?
We are talking about the lungs, you betcha, and specifically the pressure in the lungs. So we're talking about as the lung container gets bigger, pressure decreases. The lung container gets smaller, pressure increases. Good old Mr. Boyle. Actually, who was Boyle? Do you think he was covered in boils?
No, I think that's the town north of northern Alberta named Boyle.
That's what
Named
this
after
is.
him.
100%. So
Yeah.
this must be after
Yeah.
northern Alberta. We are important. All right. So what we're talking about is if we look at this here, we're looking at a beautiful closed system. Your lungs are a closed system. So we can see that we have those little boxes around. We can see that individual's super thick neck probably has a goiter. And we have PV over T or nRT. We're looking at the atmospheric pressure and the pressure inside the lungs. So what's happening? We get oxygen in, we meet atmospheric pressure, and we breathe out because we've exceeded atmospheric pressure. Pretty simple. Okay, so this is the initial pneumo slide. So whenever I say pneumo, it's obviously just short for pneumothorax. I shouldn't say obvious. If you didn't realize that, it is just short for pneumothorax. So what is a pneumo? What is a pneumothorax? And we're just talking about the presence of air within the pleural space of the lungs. Now, when we're talking about this, we could be talking about a few different ways of having this. We can have a spontaneous pneumo, which is just something that kind of happens, let's say, for an anatomical defect called a bleb, which we're going to talk about coming up. Or we can have a traumatic pneumo. So we can get air in there, let's say, if you're in an accident and you have a rib that punctures that pleural space. So there's different ways that we can get a pneumo, but the end result is we have air in that pleural space, and we don't like that. That's not fun for us. So, like I said, this can occur in a few different ways. We can have a nice healthy person who has what's called a bleb, which is what you see right here. And all a bleb is it's like a blister on your lungs. And typically this blister will form on the top of an individual's lung. So in the upper part of the lung anatomy there. This spontaneous pneumo, this bleb, this primary pneumothorax is quite uncommon. It happens more often in men than it does in women, and it happens more often between the ages of 10 and 30. And specifically, we're talking about tall men. There is some science that's showing that individuals with like Marfan syndrome or like Olympic swimmers like Michael Phelps are at higher risk for this, simply because if you have a taller person, you have bigger lungs and you have more pressure, and that top of the lung can then have that bleb burst. So if that bleb goes, we have a simple pneumothorax. And if there's no other previous lung conditions, this is a primary spontaneous pneumothorax. If someone, let's say Jay was a COPD patient or had asthma, asthmatica, that's not a word, asthma would be what I'm trying to say. Or let's say they were a chronic smoker or had anything like that, we call that a secondary spontaneous pneumo. So they actually had something that precipitated this in the first place. So when you're looking at a patient, if you have a young, active male, they have this chest pain, some shortness of breath, versus an individual who might be, let's say, 60 years old, who's a chronic smoker, who's on home oxygen, who sounds like this. My name's Steve. That person most likely has that secondary spontaneous pneumo. Now, when this happens, people don't like it. It's apparently quite painful. I haven't had one.
No, I haven't had one either.
Yeah, no, but it's apparently it sucks. Now, I would assume that it does suck. You have part of your lung tissue that opens up, it blebs, and shortness of breath, and just kind of overall shittiness, badness ensues.
So what you're telling me is right here, right? That's the bleb.
That's your bleb. Yep.
Then it ruptures.
Yep, that bleb opens right
and
up.
And then a bunch of air will go in between into the, is this the outside part of the lung on this side?
Yeah, you bet.
So it's going to let all the air go out, and then what happens is it's going to fill up the air in this area and push it in. So that's like that spontaneous pneumo, like you're saying, like there's no traumatic injury or anything else like that. This is just, it happens anatomically.
Yeah, 100%. 100%. That's exactly it. So you see that where Jay circled there. So that is the bleb, and the air does leave the lung into that pleural space from there. And eventually, what's going to happen is we're going to get equalization of pressure.
Okay.
And once we get that equalization of pressure, this individual, they don't love their life at this point in time, but it gets a little bit easier for them. Now, as you'll know, Jay, if we have a spontaneous pneumothorax, is this like a 911 thing?
Well, it could be, because you can't breathe. You feel short of breath.
This is true.
But
yeah.
like you just mentioned, though, that when the pressure does equalize, sometimes it's not a full collapse of that lung.
Yeah.
So they still have space to use. The alveoli recruitment is, but you just don't have all of it. So a lot of times you just sometimes get the chest pain, shortness of breath, and a lot of people just go in on their own.
Yeah, exactly. Yeah. So this is typically you walk in, and most often, not even emergency, you go to your family doc and go, "Oh, my chest hurts, I'm dying," and they go, "You're fine." And so treatment for this, I believe, is just bed rest.
Yeah, and they just watch it. My kids has a friend that had a couple of pneumos, and again, there's the spontaneous, and they just tell him just to take it easy and watch it and make sure that he gets better. And he usually does after a couple of weeks.
And so with your kid's friend, are they the typical case? Are they a taller individual?
Yeah, they're taller, skinny, right? Very, I wouldn't say frail. I mean, he does a lot of sports, but super thin.
There you go.
That kind of thing. So he does match that description of the typical person that has it.
That is a good presentation right there. So if you ever do see that out in the field, please understand that shortness of breath, not that we don't need to work it up properly, but that's most likely this primary spontaneous pneumo. And once again, versus that secondary spontaneous pneumo, which is when we have those pre-existing conditions, status asthmaticus or asthmatics, cystic fibrosis, anything like that.
Yeah.
Awesome. So when we look at this X-ray here, this is a primary, first degree, if you want, spontaneous pneumo. So these lungs look good. They really, really do. But this individual did present to the hospital with a little bit of discomfort in the chest, shortness of breath, increased respiratory rate. Classic presentation for someone who's having some type of respiratory trouble. And when we look at this, we can see that we have this gorgeous cardiac notch and the heart's kicking there. Life is fantastic. But beautiful. Loving that. Heart's loving its life. You betcha. Doing its best pumping job. Now, if we go to the sternum and we go just lateral to the sternum, right there, you can see that we have a little bit of an issue forming right there. 100%. That's it right there. And all that is, that's our pneumo. Now, this individual, like this lung will equalize, that pressure will get the same. And what's going to happen, believe it or not, is as that pressure equalizes, it squeezes that part of the lung so that pneumo naturally closes itself off. So this is not a surgical intervention. This isn't any kind of crazy, awesome, go down there with a scope and cauterize with your cool tools. It's literally a, hey,
Yeah.
this is equalized, get some bed rest, and this, you will get better on your own.
And you can see, like you point out, right? This is the basically still how much lung they still have to use to
Oh,
breathe.
yeah, exactly.
Right?
Like this person still has a
So it's
lot of
pretty
really,
small.
yeah, there's a lot of good lung space there. I mean, but would it hurt? I'm sure it would.
Yeah.
Like I've never had a pneumo. I don't want a pneumo, but
I hear it's quite uncomfortable.
I do hear that it's not something that you want to strive for in life.
Okay.
All right, so let's move on here. So spontaneous pneumo, what are we looking for, guys? This is your classical presentation. We've mentioned this a few times, and Jay will actually be an expert with this because he has seen more patients with this. I guess in the relative, past versus I have. Mine's been about a decade or so.
Yeah, and the thing is that you see these people, they're the people that call, they're the people that usually have chest pain. If you think of the other x-ray we saw before, that they had a pretty small area.
Yep.
So usually the ones that call us usually have a lot bigger area. You might be able to listen to lung sounds and actually hear a decrease in that area, and you don't hear wheezes, right? You don't hear crackles, but they have this shortness of breath and this chest discomfort. So we got to make sure that we keep that in check, that we're looking for a spontaneous pneumothorax.
Yeah, perfect. And that's a good thing to mention too, is on those breath sounds, we're not hearing anything advantageous to us. We're just hearing, like when we're listening, when we're auscultating, the volume just isn't the same. We will have equal air entry, we'll have bilateral air entry. However, there will be less on the affected side.
Yeah.
Yeah, definitely keep that in mind. So that's actually going to be one of your greatest tools in determining what this is. Good old stethoscope. Now, we're going to move from that spontaneous pneumo into a traumatic pneumo. Now, this is going to be a little bit more common for you first responders. This is kind of why you're going into the job that you're going into. So this can be caused by a bunch of different things. This can be a penetrating injury or a non-penetrating injury. So if we're looking at a non-penetrating injury, the most common cause of this is a rib that's been dislocated and has actually punctured that pleural space on its own. So we've gone through the parietal pleura. Now we haven't gone through the visceral, but now we have a space between the two. Okay. Or vice versa. We can have the non-penetrative injury where we kind of just get like a big blunt force injury, which causes kind of some abrupt issues around there. Now, one thing that I want you to know is that we can actually cause these on our own. So for instance, if we're looking at keeping that parietal layer intact, but going through the visceral layer, is by ventilating a patient. We can actually cause this. So if we have someone who doesn't even have to have a previous condition, but if we are begging like there's no tomorrow, we're just ignoring the signs and I'm fighting a lot of pressure here,
and you're not letting them ventilate, right? Or the air to come out, exhale.
Yeah, right. If I'm not watching my PEEP, if I'm just like a PEEP of like 20, for some weird reason, I don't know why we do that. And I'm just really just kind of forcing this in there. As Jay said, if I'm not allowing the air to escape, well, I'm just feeling the lungs up and up and up. And then that parietal layer can get a hole in it. Now I've sealed it in with that. The visceral layer gets a hole in it. I've sealed in there with a parietal layer that this is going to collapse that lung. Now, what is really crazy, that is super freaking common, but as EMS, we don't get to see it too much, is that this is very common with CPR.
Oh yeah, it does happen.
Yeah, which makes sense because if I'm rocking on someone's chest, I'm definitely going to be puncturing those nice little super thin and super fragile layers. But as EMS, we don't really get to see that because our job is to come in, we're doing CPR, we're ventilating, we've got our 12 lead on, we're pushing some drugs. But once we hand them off at the hospital, we don't have to worry about what's punctured the lungs. We need to worry about cleaning our ambulance and maybe taking a bathroom break. So I want you guys to understand that although creating a traumatic pneumo isn't something that we strive to do, believe it or not, it's kind of part of our job. It's not something that we want to do, but it's something that we will do. And depending where you are in your careers, this is a BLS lecture. So you're probably showing up on scene and actually starting that CPR. Jay and I haven't started CPR really for a long time. We're typically kind of called in later in the process. So we get there with a soft chest and our job's kind of easier. Whereas you guys are really cracking those ribs going in there and potentially creating this traumatic pneumo, which once again, not a big deal. Don't feel bad for doing it, but it is quite common. Okay, so let's say that we have a penetrating chest injury and there's this traumatic pneumo in play. Jay, what do I do? Like I'm freaking out. I don't even know my own name anymore. There's a penetrating. Someone pulled out whatever was there. Life sucks. I don't know what to do, man.
So when we're looking at penetrating injury, we're just talking about basically if someone's got a hole in their chest, right? So now we have actual space, an airway that can get into the chest. Air can get in the chest without actually going down your normal airway, right? So part of the problem is, let's go over here. We'll take a look, right? So we got this. Let's see how well I can do this. This is it's got to be a little smaller.
That's a big knife.
It's a knife, right? You get a hole there. What happens is the air rushes in, and it's going to cause that side of the, or maybe I could be fancier, make it so, right? That's the blue air going in, fills up the chest, it's causing the lung to collapse. Part of what we need to do is that we're going to come in, just erase some of that, where the hole is, right? What we need to do is we need to seal this off, is the biggest thing.
Okay.
So as a BLS provider, what our basic skill is, and which is in our scope,
I'm going to put my cheek on it.
Yeah. You could do that. We could also, right off the bat, you can take your gloved hand, right? Because we got our gloves on.
That seems cleaner. I like this.
Right? You got your gloved hand. You can actually cover it with just your gloved hand.
Okay. And not my cheek.
Not your cheek.
Okay. That's why I
Well, you could if you really want to, but
that's why I got that wrong in that test.
yeah. So the next step would be is that we can't keep our hand on it the whole time, which you could if you were really trying to get off scene quickly. But what you can do is you can come in and get an occlusive dressing, occlusive meaning that air can't get in and out of it.
Okay.
We put it over the hole. There's my occlusive dressing. And what we do now currently, initially when we started this, here we'll do a blue. We're going to tape this side of it. We're going to tape this side. And initially we used to just tape three sides.
Three-side occlusive dressing. That's what I was taught way back in the late 1900s.
Yeah. And that's when you had the horse and carriage.
We did. Yeah, you betcha.
And the idea behind that was if you built up enough air pressure within inside that chest wall and cavity, the air still could leak out through the bottom. Standards. Currently what they're saying now is that we want to tape all four sides because what we really don't want is air getting in there. We want to make sure that all four sides are sealed and we can have that air because the air will follow the least resistance, right? Which is through the chest.
Okay, I like this. This
all right.
Makes sense.
So we're going to talk about something else here in the next little bit that will come back to this.
So I'm actually going to interrupt you quickly for 1 second, Jay. So let's say I have this beautiful picture there. Life is good.
Okay.
Now, this is a BLS provider. I roll on scene. I'm feeling like this is the best day of my life because now I love these pneumos. I'm a pneumo expert.
Yeah.
So I throw in my four-side occlusive dressing, or let's say I'm getting ready to throw this bad boy on, and an advanced crew shows up. Just curiosity's sake, what might an advanced crew be throwing on there? I remember SAM seals. Is this still a...
Yep, some people still have them. They're the SAM seal, right? So when we're talking about a SAM seal, it's a big piece of plastic,
okay,
and it basically has a one-way valve on it.
Okay, fantastic. So that one-way valve means that if enough pressure builds up in that chest, it can release itself.
Yeah, and the air comes out.
Oh, man, I like that.
Right? So basically, if we think of the SAM seal, right? So you got this big circle. Your hole will be here in the chest, but over top of it, you want to put this a piece of big plastic. It will stick up a little bit, and it has a one-way valve, so air can go out, but the air can't go in.
Oh, gorgeous. The valve literally goes over top of right where the hole is.
It makes it really simple to use.
I like that. I like that a lot.
But usually, the service I work in, we just use the four-side dressing, but you have to be aware of some things, right? You have to reassess your patient every 5 minutes with people when you're in this situation.
Oh, definitely. This is not a stable individual.
Yeah. Even if you don't have a pneumo, a sucking chest wound, in this type of trauma, any type like this, where you think you might have problems with the chest and airway, you need to do reassessments. You need to keep checking that patient over and over.
Yeah, because I guess if things get worse, that lung could potentially fully collapse.
Yeah.
So enough air goes into that pleural space, just squishes that lung, just squish, gets smaller. And now your patient is effectively working off of one lung.
Right. So when you think about it, let's just erase some of the stuff here. We have all this lung space. This is all the recruitment we need. We need to be able to breathe. It helps us, right? But if that air gets in there, we get enough air, you will have nothing left.
That sucks.
Which is not going to be very good.
No, that actually looks like
we
it's
need to
kind of
seal
a
it
bad
off.
time. Now, at the end of this lecture, guys, I'm going to talk about two cool things the body does, and naturally when this happens. But we'll leave that till the end. Let's roll on. Okay, so we're moving on to a tension pneumo or a tension pneumothorax. This is bad news bears. This is a potentially life-threatening condition. This sucks. So that interpleural pressure, it's now exceeded that of the atmosphere. Okay, so this lung is gonzo. So when we're looking at this photo here, or this x-ray, I should say, the lung on the right, which is on the left-hand side of your screen, that is the bad lung. There is no lung there. Okay, it has completely collapsed. Now on the, yeah, perfect, right there.
Right there.
Now the lung on the left-hand side, which is on the right-hand side of your screen, that is a gorgeous lung. That thing's filled up with oxygen, and that's the lung that's really attempting to keep this patient alive right now. All right, so let's go back to the lecture portion here. So like I said, this is super life-threatening. Now, this, like I said, is life-threatening. Okay, this affects not only the lungs, which we saw in that x-ray, but the heart as well. So all that squeezing chest pressure, all that interpleural pressure is pushing on the heart. Now it's pushing on the mediastinum as a whole. So we get tracheal deviation in these patients. Okay. So this absolutely sucks. People don't like this. If they're conscious, they're freaking the heck out like there's no tomorrow. Their life sucks. So yeah, so the heart's kicking right there, and all of that pressure is pushing on the heart. It's pushing it over to the side, which is why we get that tracheal deviation. Now, it's kind of hard to see in this photo, but yeah, so there's that. We're just going to draw it in. That's fantastic. That is a deviated trachea for sure.
So would you see the deviated trach right off the bat?
Oh God, yeah. Yeah, like, so, I mean,
Right. You know what I mean? Like that's more of a late sign, but
yeah,
that's
like on this one, you would see it for sure, definitely. But let's say you just showed up from let's say a traumatic pneumo, like a simple pneumo that turned into this tension pneumo. No, if it just turned into a tension pneumo, it's not going to be super apparent. The first things you're going to notice are like that increased respiratory rate, that pain on breathing. You're going to have ipsilateral chest rise. And so the crazy thing here is as this patient's breathing in, their good lung now has to meet the pressure of the one that's full of air. So the chest, it takes a while for the good lung to actually reach the same height of the chest as what the bad lung is already kicking at.
So their workload increases too, right?
Oh, through
the
the
idea
roof.
of them trying to get that air. It's again like we're talking about like a balloon, right? You blow into a balloon, it gets harder to blow. If I put that balloon inside a like a pop bottle, near the top of the pop bottle, when I blow in, it's going to be harder for me to blow that balloon up because you're going to have the pop bottle restricting the ability of that balloon.
Exactly, right? So if you roll up on scene to someone who has a tension pneumo, then yeah, you're going to see that that mediastinal, that trachea deviation. But if this is something that progresses while you're working up a patient, no, it'll take time. It's not super instant.
So yeah, another check is when we talk about lung sounds on this side are going to be good.
100%.
You're not going to hear anything over here.
Not at all.
Right?
No.
You're not going to hear wheezes.
Nope.
You're not going to hear crackles
Nope.
or schmutz that's in there.
Nope.
This is nothing. So when you go to listen to the patient, and that's just like the progression of the tension pneumo, you may not have a lot of the signs showing up because we have problems with blood pressure with the tension pneumo. We're going to have problems with rate, but it might be just starting, but you probably aren't going to hear any sounds on that side.
No.
It's because the lung is not filling up.
Now, what is in there though, Jay?
Well, we're full of air.
So what is one thing that I can do as a BLS practitioner to kind of allow me to understand if maybe I just don't know how to auscultate or if there's air in there?
You could use, you can tap the chest, check for hyperresonance or dullness.
There you go. So we get hyperresonance in these tension pneumos. So you're tapping on it and it's just going to sound like, well, it's hyperresonant. How do I explain this with better words?
It will sound more hollow.
There we go.
It has more space and it will sound different from one side to the other.
Yes, exactly.
So you gotta do the comparator to make sure that.
Exactly. Whereas you get more of like a thuddier solid sound on the good side, you get that hollow sound on the bad side.
So you guys just basically, right, you do the tap, the two fingers.
Yeah.
You do the other side, then you want to do the comparator to make sure that you can hear the difference in the two.
And that's actually a very good thing to state too, is you always must go from the good side to the bad side. You need to understand what good sounds like so you can understand what badness sounds like. And that's throughout anything you do in EMS. Like if you're looking at something good, you need to compare it to something bad. That has to be compared to something good. You have to have some type of baseline, so to speak.
Exactly.
Okay, awesome. So let's see what else do we have here.
All right.
So, yeah,
So what we're looking for.
there we go.
I think we're already talking about a bit about this.
Yeah.
Right. So let's take a quick look. Maybe we'll just double check everything.
Okay, cool. So that ipsilateral or that contralateral chest rise. So what's happening here is that one side of the chest has to kind of meet
Like-
with the other side.
Right. So when I'm breathing, the one side won't come up as much.
Exactly. Yeah, it has to kind of fight to kind of make its way up there to where that other one is, because the other one's full of air already.
Yeah.
So if I'm filling up my other lung, it needs to catch up to the side that's already full of air.
Yeah.
Now, once again, it's not the lung that's full of air; it's that pleural space.
So how would I check for that? I probably can put my hands on their chest.
Yeah, watch your chest rise.
Or chest rise, and you can probably feel the difference that you'll feel the one hand come up before the other.
Totally. Exactly.
Okay.
Respiratory rate. Oh man, if I have one lung, I have half the amount of oxygen that normally comes in, so I'm gonna have to start breathing faster.
Exactly. That's that dyspnea. Right?
Yeah, exactly. That's that dyspnea. Now, here's something you also want to know is if I'm trying to breathe faster to get more oxygen, you also have to note that your patient is not going to feel happy with breathing. It sucks and it's painful. Right? So look at this individual over the side here. This doesn't look like a good time. They're doing a needle decompression. Not in your scope, but we're going to talk about it here. But like that doesn't look like it's fun to breathe. And this patient is going to be shallow, rapid, guarded breathing.
Yep.
You know, it's going to suck for them.
Yeah, they're definitely not going to be very happy.
No.
And you'll see a lot of stress again, like we talk about when we talk about shock, different types of shock. Sometimes, like these people are going to have that anxiety. They're going to have that restlessness. They're not going to be happy with what you're doing.
No, definitely not. So, for instance, Jay, like when you roll up to a patient like this, do you tell them to breathe deeply? Do you tell them to try to control their breath? Like, what do you tell them? What do you coach them?
The biggest thing is I just coach them. We try to get their breathing a little slower because we want to be able to get them a longer inhale because we got that lung, only the one lung we have to get working. And we also try to coach that breathing out while we're trying to support the other side. And like you said, as an advanced care provider, we're going to do a couple other things that BLS can't do.
Yeah, exactly. So
one in particular.
Yeah, we're going to decompress. We got beautiful turcles, which are
Right.
kind of short and stock, so needle decompression. Also, something that is in the BLS scope, at least here in the province of Alberta, even though it's not well understood, I want you guys to start getting super comfortable with your waveform capnographies. Okay, I want you to look at your end tidal CO2s and understand the trends. Okay, it might not make sense now, but if you can kind of get yourself used to it, like Jay, when you are looking anything respiratory, what is your like go-to vital?
Well, the go-to is always CO2.
100%.
And the reason it's CO2 is because it's immediate,
yeah.
right? Because SpO2 does have a bit of a curve of time.
Yep. Upwards of 10 seconds in all honesty, depending on what you're using.
And if you talk to some of our medical directors, they even said sometimes it can be up to 2 minutes.
Yeah.
Except for a long period of time. But CO2 really is breath per breath. You can see it after you get 2 breaths. You can see your waveform, you got your numbers, and you can titrate your actual ventilations based on that. And whether you've actually done treatment to make it better, does it improvement?
Yeah. So as Jay and I, as we're ventilating a patient, we're not looking at SpO2. We're actually looking at the waveform and the value of that CO2. Yeah. That is telling us if we are doing our job properly or not, which is kind of ridiculous. Because do you ever just look at that life pack and think, stupid life pack? Why are you telling me what I'm doing?
Well, and the thing is,
you can't judge me, machine.
Oh, we gotta be real because that damn life pack's smarter than all of us, right?
Oh, man, I know.
So just because really quick, just so people know, well, we're gonna keep talking about this damn waveform, right? Maybe not be the best waveform, but we want to see a waveform like that.
Yes.
Actually, that's not a very good line there, but
oh, hey, the second one was really good.
Yeah, I know. So that's kind of the line you're looking for when we're doing it. If you don't see this at all when you're looking for your CO2, right? If you don't have that nice kind of mountain, it will be sloping something close to that step, you're not having good ventilation.
No, and your patients.
And they're probably not oxygenating well either with that. So the best part is that when you're looking at it, look for that and titrate to that while you're doing your ventilations to that.
Yeah, exactly. Now, with this, guys, the reason why this is super important is, like we said, this tension pneumo, this is pushing on that heart as well. Okay, so perfusion is really not going to happen. So not only can I not get the oxygen in, I'm squishing my heart. Okay, and
so what kind of shock is that?
Well, we're going to get there in a second. But if my heart's being squished and my ejection fraction decreases, not only do I not get enough oxygen in, but I can't even circulate the oxygen that I do have going around the system.
Yeah, so all that cool hemoglobin you got, it's got all that oxygen from that one lung.
Yep.
It's if you think of like a prime delivery driver, he now can't get around because this doesn't have, like, he's like driving in first gear,
Yeah, exactly.
right?
Right. And
Can't go as
Amazon doesn't
fast.
like that. Amazon
No,
wants to get their shit done.
they want you there. Well, you can order
I,
stuff today, and I got stuff coming later. Can't wait till they show up, actually.
right.
But
I want them there right
yeah,
now. And if I can't get my product, which is oxygen, I'm not
yeah,
happy. And then sadly, in this case, instead of me sending a message to Bezos being like, dude, where's my spaghetti that was supposed to be here at noon, I'm just gonna most likely die. And so
yeah.
this is a little bit more drastic, I guess. But yeah, this sucks. And so we will talk about the shocks. Do you want to mention it now? Do you want to do it later?
Oh, we got it coming up.
Okay, we got it coming up.
It'll be
We'll talk about it coming up. Okay. So yes, this tension pneumo, super big deal. And as Jay said, as advanced care providers, and I'll let him kind of talk about this just a little bit, we can do a needle decompression, which is super fun. So Jay, if you want to just give a quick brief.
We'll kind of go over it. So here's our fancy chest again, like we talked earlier. I'm gonna, because you know how well I like to draw hearts. There's my heart. It sits in there.
All right.
Right. We get this lung is collapsed.
Yeah.
All the air has gone in. We actually, this is a tension pneumo, so we have full of air.
Okay, cool. So that entire
so
space.
It's pushing. So what's going to happen is all this stuff is going to get pushed over. So as this lung fills, it's going to push against the heart.
Okay, so I'm getting that tracheal deviation.
So now
poor ejection fraction.
We're actually going to put all that over. We're going to have poor cardiac output.
Yep.
So what happens is, as we saw in that other picture down here, really quick, you can see where there was a needle. So as a advanced care paramedic, what I'm going to do is actually put a hole in their chest.
Well, that seems the counter. That doesn't make sense, man.
But I did make a mistake here, though. We just said they had a hole in their chest. This is actually sealed, and this is what we're talking about: is that they've had kind of like blunt trauma, CPR, right? So I just want to be clear: this is a closed system, right? Where we talked earlier. This is not your sucking one. We already talked about that. This is that closed tension, and the reason it's a tension is there's nowhere for this air to get out.
That's right. So I've been in a car accident. Yeah. The steering wheel hit me, broke my ribs, and I punctured that myself.
Right. So this system is still intact. We got air. So part of the lung is, has a hole in it. Air goes in, causes it to collapse. And then what happens is eventually more air comes in.
Yep.
And it doesn't know what to do. So it's going to push against everything. So what will happen is we come in as advanced care provider. I'm going to take, it's probably bigger. It's a lot smaller than this, my fancy needle here. And I'm going to go into what is it called? Second intercostal space.
Right,
go over top of the third rib. What we do, and because we're talking about BLS, we're not going to get to it. But what we'll do is we'll puncture a hole there, and we have a really cool syringe, kind of like thing's pretty big. I can push it through. It'll actually go green when it enters.
Yep.
And I know it's in. I can pull the needle out, and there's just a flexible catheter that just goes in. So we don't actually put the needle into the chest. That's just to get through the skin and the tissues and the muscle, and then we leave the catheter. And usually what happens is we'll get a rush of air. If we're using a torcal, remember before we talked about putting that 4-way sticker on, we actually, on the torcal, we actually have a valve.
Yes.
So if we see them developing tension pneumo again, we go in the valve, it can release the air. Now, sometimes if you don't have the torcal, the fancy one, we just use a big ass catheter.
Yeah. I mean, it's a little bit more on the barbaric side, but honestly, guys, it works.
Put it through. We can either do it up on the top of the chest, or we can do it also lateral as well.
Yeah. Fifth intercostal?
Yeah, fifth intercostal on this side.
Yeah. So a neat thing with the Turkles is that they do have that beautiful indicator on them. They do have that valve on them. And for anyone who goes out there and hunts, another way of knowing if you're in the right spot is once that air comes out, it smells very much like when you're field dressing around the chest cavity of an animal.
And when you do get that, you will hear a rush of air.
Yeah, you'll hear like it shoots out.
And you'll notice your patient will start looking better.
Almost instantly.
Yeah. All of a sudden, you notice the chest rise will be the same.
Yeah.
For the most part, they'll actually have a decrease in discomfort. They actually might become more alert. Right?
Yeah,
because they have more oxygen, right? They're
100%.
not as hypoxic.
And that's a good thing to mention too. Is one of the reasons why this sucks so much is because it's not just my lungs, it's not just my heart, it's my brain. Because my brain doesn't have any reserve for two things: one, energy, glucose, which gets turned into ATP, and two, oxygen. Two really important things for any system.
Yeah.
And my brain doesn't have a reserve for either. So the second my ability to perfuse has decreased, my brain gets an initial hit right from the get-go.
Okay, so just quick review, just to make sure.
Yep.
Tension pneumo. We have a closed space.
Yep.
Simple what was the other one?
So we have these. So we have a traumatic pneumo, which can happen from, once again, that we can just be bagging too much. Okay, this can happen closed or
That's at an open. If we have an
yeah.
open pneumo, so that's that. You hear the sucking chest wound they talk about. Sometimes you'll see bubbles.
Yeah, you get
from
that
the hole
frothy blood
they talk about. So,
and then we have our spontaneous, which is a primary, secondary, or first degree, second degree. And once again, the spontaneous, the first degree of the primary spontaneous was a healthy person who has that bleb, that blister on the top of their lung that typically goes. And the secondary was the pre-existing condition, which is, let's say, the asthmatic, the smoker, the cystic fibrosis, whatever. That's kind of like weakened that tissue.
And the next step too is like we have the open and closed.
Yep.
Closed usually leads to, you can lead to a tension pneumo. It doesn't always happen.
Yes.
But like I said, it's life threatening. We have to do something about that.
Yes, you can't just pretend like you didn't
Now,
see that.
can I have a tension pneumo with an open?
You can.
Right? So I can get a penetrated wound depending on the size, what I'm stabbed with. If I'm stabbed with an ice pick, right, it's pretty small.
Yeah.
There's a chance that it could clot up and seal up.
Exactly.
So you still, even though you have that open wound and you think that maybe because it's open, the air should be able to get out of there, it won't happen.
So with these, Jay, just out of curiosity, is I was always taught that with a typical laceration, I put a gauze on it.
Yeah.
And then I see some blood, so I put another gauze on top, and I see some blood coming through, and I put another gauze on top. Is that the same with the chest?
I don't think so.
It's not,
I
right?
don't.
Because as you were saying, with that clot there's, what do I want to do with that clot? I might want to get rid of it. That's right.
Yeah.
So that way we don't, like, we want this system to be open, right? Because we don't want that tension pneumo.
So one of the things we do, like we just talked about too, is, and I don't know if we did it already, was that we put on that, let's go over this one. Remember we put that bandage on?
Yes, our four-way occlusive.
A 4-way occlusive.
Yeah, I love
right?
that bad boy.
We taped it all on.
Yeah, she's taped on like there's no tomorrow.
So this is an open pneumo.
Yeah.
Correct. But what we don't know
I tried
is
putting
that
my cheek on it earlier.
you did. Yeah. And we could actually, because we have air entering through a hole here doesn't mean we don't have air also coming in through the lungs, right?
Exactly, because I'm still breathing.
So now, because I fixed the hole, we can cause a tension pneumo because we don't have any room for that air.
Oh, man.
Right? So what we need to do is that if we look like we have signs of that, we actually should just undo a couple of the sides and be able to allow air to come back out.
Oh, kind of like, what's that sound that you make when you drink a lot of pop? What do we call that? We burp it. That's right. We burp the dressing.
So you take part of the dressing off. If it's really mucky and stuff, you can always reseal it.
Yep.
But just remember, as a BLS provider, right, if you start seeing signs of a tension pneumo, which you never had before, and they had an open pneumo, because you've closed the system off or wherever it is, you need to be able to undo that.
Yeah. So if you see that the dressing looks like there's even like a little bit of raise in it, I want you to understand that it means there's something there, whether it's air or some blood. But as Jay said, we want to release a little bit of that, get whatever it happens to be out. If it's blood, if it's just a bunch of purulent grossness, or if it's air, we want to get it out.
Yeah.
Yeah.
All right. Let's move on to the next part.
Let's do this. Okay, guys. So I'm going to keep you on this tension pneumo for a few more seconds. I do want to mention some really important things here. So we got this tracheal deviation, this medial sternal shift. We've talked about this. I won't beat that dead horse anymore. But this JVD, this jugular vein distension. So those gorgeous jugular veins up on your neck here on either side, they are lowering themselves into these great portal veins, like your subclavian going into that superior vena cava. So why, Jay, why, if I have this tension pneumo that's pushing my heart over and making my heart not be able to squeeze as much, why would my jugular veins get distended?
Because I'm not pushing enough blood to the rest of the body, right? It's kind of like backing up into that area.
Okay, so because of that,
cardiac output isn't enough out to the body, right?
Fantastic. So I'm getting that buildup, and so I'm seeing these jugular veins distended. So on, let's say, any scenario you have, if you ever have tracheal deviation and jugular vein distension, I want you to think, oh, crap, this ain't good. But now you have a heart that's not doing its job, and you have lungs that are squishing on that heart because we have that hyperresonance to say that I have one fully collapsed lung.
And you probably will see the jugular vein distension.
Oh, yeah, it's
before you even see the trachea.
Yeah,
Like,
exactly.
right. So
this
that
takes a
so
while to move, whereas this is
so you can see
really
that
quick.
it's the progression, and that's one of the things clinically we have to be aware of, and always doing that reassessment.
Exactly.
Right.
Good work. Yeah. Once again, 5 minutes. Now, the subcutaneous emphysema, these are those like corn pop crackles that you will hear. So that's air that's trying to escape and it's moving its way up into some of these different tissue layers. And so this is subcutaneous. So you can push on it, you can hear this popping. And I got this caveat, this nice little star here about the hypoxemia. So we're going to talk about that later. But just understand, we'll talk about hypoxemia.
There.
All right. So we have air in the lungs. Well, I mean, we should always have air in the lungs, but we have air in that pleural space in a bad way. We talked about that. Now we're going to talk about what happens when we get blood in that same space. Now, I'm no expert.
Blood.
Blood.
Yeah.
Like, yeah, blood. I want to suck on your blood. I believe this is Jay's favorite type of thoraces. And I don't know for a fact. I've never actually asked him this question. I'm just going to assume that you love a hemothorax. It's a Thursday afternoon. Your shift's just about done.
I'd rather deal with the air ones.
You want to? No. I think you're just looking for a good old hemothorax. I get that vibe from you right now.
Really?
Yes. Okay, guys. So air can collapse a lung, as we just talked about. So can blood. Blood is thicker than water, and according to Dom Mazzetti, nothing's thicker than family, or more important than family. So blood is just as important as family.
Kind of.
Fast and the Furious.
Well, actually, blood's more important
Well, I mean,
because it gets the oxygen and the glucose to your brain.
oh my,
Right.
yeah, jeez. So you guys,
Well, I guess your family could do that too, kind of.
well, if
They give you food and stuff, but
anyways, so Fast and the Furious got it wrong. I don't believe
Yeah.
that though. Those movies are very accurate to how the real world works. Okay, so a hemothorax, guys. This is blood in that same space. And what we're looking at are for the exact same signs and symptoms: shortness of breath, trouble breathing, my life sucks, there's pain, blah, 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 blah. A hemothorax has a bunch of different categories that is, we as EMS practitioners literally don't give a crap about. I'm not going to x-ray a patient and say how much blood is in that space. And even on an x-ray, depending if my patient is supine or what position they're in, it can show different amounts. And Jay, you work in EMS, right?
Yep.
Do you give a crap about that?
No, not that moment.
Yeah, exactly. No. Yeah, I don't think I would either. Okay. So when we are looking at a hemothorax, guys, I just want you to know this. You're going to go through what we've already talked about. You're going to listen to those breath sounds. Life is good. Auscultate the apices and the bases. And you're going to say, something is wrong. This one affected lung doesn't, sound right.
So if you look at these lungs, when we listen, we're going to have probably decreased air entry.
Yeah, I would
on
definitely,
the right side there,
definitely say that there's going to be decreased air entry. And so what are we going to do? Because we said that if you will hear hyperresonance on the pneumothorax. So Jay, what would I hear on this side?
We're going to hear more dullness.
Dullness, okay.
It's filling in the area, right?
With a nice
thick
fluid.
Compared to air.
I mean, I'm pretty thick too sometimes.
Yeah.
I have trouble grasping onto simple concepts, but I think I got this one. I think I can understand this one, Jay. Now, we have now determined that we have a hemothorax versus a pneumothorax. What am I going to do, Jay? I'm a practitioner, and I know I have a hemo.
Well, especially BLS, because that's what we're talking about today.
Yes, exactly.
BLS, we're basically just going to treat the signs and symptoms we come up with. Shortness of breath. If they're hypoxic, their SATs are low enough, like below 94, depending on where you are, because we know that number changes, whether it's 94 above 95.
Yeah,
that
exactly.
Kind of thing.
ITLS
we
versus,
we want to put oxygen on this patient. We want to help out, recruit as much oxygen into the system as we can, because we've lost part of that lung as well.
Exactly. Okay, I like this. So as a BLS provider, I am simply just trying to treat the signs of this patient. They're struggling to breathe. Cool. Let me help that out. My SpO2 looks low. Fantastic. Let me help that.
How about positioning?
Ooh, there's a good question.
Do you think, like, because I do have, say, this is where my all the blood's collected in this type of lung.
Yeah. Okay.
This is my good lung, right over here.
Yeah, that's a good question.
Could I lay them like if it's on this side, I could go left recumbent?
Yeah, right. So depending on that side, so Jay has a left lung that's filling up with blood, so he would want to go left recumbent, so that way we're not putting that pressure onto the good lung.
Yeah, right. So the idea is that you can actually create space. So this good lung here can easily
Fully expand.
fully expand.
Exactly.
Right. Because this is the side that we got the problem on.
So even if we have to roll this patient for some reason, let's say we have to spine board them, which is going to be super, like, we're doing full spinal mobilization here. I don't know why we're doing it, but let's say we've made that call. And so I would want to roll this patient towards that affected side instead of squishing the other side with that, that big closed container full of blood.
And we don't even have to do much. Just put a bit of blanket underneath the board, right? Tilt them that way, and all you're doing is like shifting some of the weight to the other side. It allows them to breathe better.
Exactly. Cool. That's a very good
There really
point
isn't
here.
much you can do with it.
No, but let's say.
But you gotta let people know if you're doing right. You gotta let the receiving hospital know you have this.
Oh, definitely.
Right, because this is the problem: is that you don't want to show up and go. They can be ready to do a finger thoracostomy, right?
Yeah.
They can put a chest tube in. They can be ready for all that stuff when you show up, so they can do it right away. And again, same with the pneumothorax, or when we let all the air out like an intention, they get a lot of relief. They'll get a lot of relief when they're able to put the chest tube in.
Exactly. So definitely you want to patch in that you have a possible hemothorax for sure. Now, as a advanced care provider, Jay, you have confirmed that you have a hemothorax. What would you do? Just to teach what's kind of coming up for some of these individuals.
Well, one of the things too is that we want to make sure it's a hemo. We're not positive it's a hemo. It could be a pneumo.
Yep.
So we still might look at decompressing the chest.
Okay, fantastic. So let's say we try a decompression and nothing happens. Would you be able to place a chest tube?
No, but they are looking. The rumor is they're looking at us doing finger thoracotomies. The military does do it.
Yep.
In those situations, it's supposedly not such a.
Apparently, pretty easy.
It's pretty easy from what they've told me, but it's something they are looking at for us to do.
Now, so the basic kind of take home with this, guys, is this is a big deal that needs to get to the hospital so they can provide that relief that we can't provide at our level yet. But
Exactly.
hopefully, come down. I'd like to have another.
Well, next expand our service.
Yeah, 100%.
Or a scope, right?
Exactly. Another
Being
tool
able
in
to
my
do that.
toolkit's always a nice thing.
So that's the biggest thing. We might decompress it because you don't know whether it's a hemo.
Yep.
You may not hear any air come out, and odds are, if it is blood, you're probably not going to see much blood come out through a small catheter like that.
No, exactly.
You're not going to be draining them.
No, like that's just exactly. You need when you do a chest tube, it's quite a big thing that has to go in there. It's not a small tube; it's a big tube that has to get in there in order for that blood to drain out. Okay, so that's this. Let's see what else we have here. What to look for. We talked about this. This is the exact same stuff that we've mentioned 100 times, guys. You're going to have a patient who has an increased respiratory rate, pain or discomfort when breathing. But because this is a hemothorax, we have bleeding, which means their blood pressure is going to go down, which means their heart rate is also going to jack up in the early signs of shock to kind of compensate for this.
Yeah, we see and that's right. The rate is going pretty quick.
Yeah, exactly.
The other thing too is like if you look at this X-ray,
This looks fine. I don't know why they're complaining.
yeah,
I don't see anything wrong with this
You
patient.
should even see how far it's creeping to the other side.
I don't know what you're talking about. This is fine.
So remember before the other X-ray we looked at, the black was a good area where you really see a dark space.
Yep.
So this is the if we're looking at this is their lung right now, the functioning lung that we can see. All this other stuff is filled blood.
Yeah. So you're saying then, Jay, that it is possible that if I have a massive, major hemothorax, that I might even get mediastinal and tracheal deviation, mediastinal shift, I should say, and tracheal deviation.
That's what I'm saying. If you can see it started in this X-ray, you can see this thing is pushing
it right
all
there
the way over there, right? Like it's creeping to the other side.
So this,
like you said, this is probably right here. Maybe I should see if we can do another color. You can see right here, right? That's a lot of lung there that should be functioning.
yeah. So that heart's probably not pumping out that well either. Then,
So you think about it, we got our heart sitting in there.
yeah,
Beautiful heart.
lovely heart.
And you got all that pressure against it, right? So it's basically that heart's got a vice against it, right? So it's just got that squeeze. So you just keeps as the blood fills up. Same with the air when it happens in a tension pneumo. It's just like being in a vice, and it just keeps cranking the vice tighter.
So when I told this patient to walk it off, and they shouldn't have called me, that might not have been the right thing.
Yeah, this is probably the one that you don't want to.
That's why I was written up again. Hey,
Yeah, sign that refusal,
man,
right? Or cancellation, right?
Dang it.
Yeah.
Dang it.
It's gonna be a long time in the waiting room, so you should just stay home. So
was
that's the biggest
wrong.
thing.
It's because I didn't have an x-ray with me.
Yeah.
That's why. Also, guys, this comes back down to saying we don't exactly care what the level of this is. We don't have x-ray technology on our ambulance. Well, I mean, okay.
We got one.
Yeah, I know. It's like, let me stop.
We're in Edmonton, Alberta, so we do got one truck. We have a truck that does CT scans.
Yeah, we actually
of the head, but it's really hard to get somebody's chest into it because it's only the size of a head.
That sounds like you're not trying hard enough, Jay.
Yeah.
Anyways, so let me stop myself. We don't really care. We typically don't have access to this right away. So we're just going to treat them all the exact same way. And as Jay said, we're going to be looking at those vitals and just trying to make sure we compensate for what's exactly supportive care. And another thing that we should mention too is always tell your patient that, I don't want to say keep them calm. Calm down. God, we're getting you to the hospital. What's your big deal? Yeah. But try to comfort them as much as possible with all these.
Call ALS. If you're a BLS crew,
definitely.
A lot of these tension pneumo, you want to call in ALS. You want more help.
Yeah, like we love, we're here to help.
Yeah.
Whether or not we are like, I love hemothorax. Yeah. Jay loves hemothorax.
Well, and
anyone here who works in Edmonton, Alberta, I want you to always request this Jay for those calls. Even if he's not on shift, just ask for him and see what happens.
It's like my wife said. She goes, I hope you have a good day at work. But she doesn't want me having too good of a day at work because that means it's a bad day usually for somebody else.
Exactly. The more fun we have, the less of a happy day it is for
somebody else.
Yeah, exactly. You wouldn't believe what I got to do at work today. I did a cricothyroid me. Oh, that probably means a bad thing for someone.
Exactly.
Hopefully the patient is the right patient for that. Okay, guys. So what we're going to talk about next is that the hypoxia that I wanted to talk about. So let's go back a little bit and talk about hypoxemia. And then I think we're just about
ready to wrap it up.
Okay, cool. Okay, guys. So I wanted to bring you back to this hypoxemia and pneumothoraces kind of concept that I've mentioned a few times. So when we look at hypoxemia, the big thing that we're looking at is simply the kind of partial pressure of oxygen within the blood is less versus hypoxia, which simply just means that I'm not perfusing my tissues. They're totally related. The partial pressure of oxygen is not being there, therefore I can't get that oxygen to my tissues. But I wanted to kind of bring this back full circle, so to speak. So when we're talking about those simple pneumothoraces, that simple pneumothorax, that bleb, even with those underlying conditions, what we were kind of looking at was, okay, you know what, we kind of get the equalization of pressure and these close off on their own about 24 hours and done. Okay, so that person's hypoxic state should kind of go back to normal in about 24 hours there. That's what we're looking at. So as we mentioned earlier, this was not, they might call 911 for sure. They might call us and we'll show up there and do our thing and treat them with the utmost kind of like respect and care as we do with all of our patients.
Oh. I just thought of something too. And they might call.
That you don't want to do that?
But they might call you because they have chest pain.
Yep.
Right?
Oh, yeah.
And the idea that as we talk about differential diagnosing, right? So that you get there and you're thinking, it sounds like chest pain. They're acting like chest pain, but there's the story isn't adding up, right? Your clinical findings isn't adding up. It's not a cardiac event. It could be leading to a cardiac event
totally.
if it's a tension pneumo, but that for a simple pneumothorax, you might be going there thinking it is a cardiac chest pain and not a actual simple pneumo.
Yeah. So actually, here's a question for you, Jay.
Right.
Let's say I'm a BLS practitioner and I do work this up as this is a chest pain. Let's say I'm just kind of, I show up, I think chest pain, I see chest pain. So that's a big problem that we have as practitioners is if we kind of look at a previous call and kind of look at this call the same way, saying that chest pain, that this looks the same. Let's say I gave this person some ASA. That's in my BLS protocol. I have chest pain, I give ASA. Would that make this worse?
Well, probably not if it's just air.
Exactly.
Right, we're talking about air. So it's not a pneumo. But there's the thing is if it is a pneumo, and the thing about ASA is because it's an antiplatelet aggregator. I don't know if I said that right.
Platelet aggregation inhibitor.
Like alligator.
Yes.
Right?
It's an alligator.
Right. It helps makes things slippery. So
yeah.
It won't clot.
Exactly.
So if you're having a pneumo, it's probably not going to be a good thing for that patient.
Yeah, especially a hemo.
Yeah. And that's what I meant. Hemo.
Yeah.
Like the pneumo, probably not going to be much. Simple pneumo is not a big deal. But you just got to be aware of that when we are taking a look at our patients, we need to make sure that the story's adding up and our clinical findings. And again, we really have trouble with biases.
100%.
Right? Because I think this is the third chest pain call this tour, and this is what it is, this is what it is. But it just, sometimes you get that thing where it just doesn't make sense. Or if you're the partner to the patient that's leading the call, don't be afraid to say, hey, I don't know if this is exactly chest pain. I think it could be a simple pneumo.
Yeah, it'd be like, you know what? Let's take an extra second and let's repercuss.
So-
Let's get that sound. Let's search for that.
Now we're on that sidetrack. So what we're gonna finish up with the hypoxemia.
Oh yeah, geez, yeah. Back on hypoxemia, that's fantastic. So that decrease in the partial pressure of oxygen within the bloodstream can lead to hypoxia, which is that simply that oxygen's not getting there. So the simple should cure itself within about 24 hours. There, that's good. And then this gorgeous, like everyone wants to look like this. That's sexy. All right. Oh, whoops. Jay, save me.
Oh no, I think we've had a disconnect.
That's my fault. I shouldn't be allowed to touch the things and the stuff.
That's why we can't have nice things.
This is why we can't have nice things. Anyways, so as Jay's getting us back there, so we're looking at the difference between hypoxia and hypoxemia. So we need to monitor this at all times. Okay, we need to make sure that our patient's vitals are there at all times, especially the SpO2, and like we said before, looking at that CO2. Okay, so when we're looking at hypoxemia, so this is that low partial pressure of oxygen. If this is a long-standing thing, for instance, if I have, once again, let's go into cystic fibrosis, if I have asthma, if I have COPD, if I'm a chronic smoker, if I have had a long time low partial pressure of oxygen, my body's going to compensate. My hemoglobin's probably going to be higher and stuff like that. But for a long period of time, if this is a patient that's had this for years, it's probably going to make your life harder.
And shorter.
Yeah, their life's gonna be short. Yeah, definitely, 100%. But like, I mean, as a medic showing up on this, you're probably not going to enjoy this, right? This is probably going to be a bigger pain in the ass
It's
for
a
you.
more complex call.
Yeah.
Right? These patients have more complexity to them. They're on more medications. They might have other medical conditions as well, right? That they have on top of this problem.
So as you fix one problem, there is a chance that you're going to extract a secondary or a tertiary problem. Now, as we start going through this lecture series, or as we start kind of adding on to this, you guys are going to see different things that we can kind of like add on to all this to make things make sense downstream. So for instance, if we do have a patient with, say, diagnosis A, and we do treatment A, I want what you will be able to see down, in weeks' time or whatever, is that by doing treatment A, what does that mean for diagnosis B that wasn't there? And you'll understand these things so the vitals will make sense. Because sometimes you'll do a treatment and be like, that's not what this is supposed to do. And our goal is for you guys to understand that.
Yeah, and the thing is understanding that what is what's down the line from it. So you make one treatment, something changes, and you might think that treatment didn't work, or you might think something got worse, but really it's just how the patient should be responding to that first treatment.
Exactly.
Because of their other diagnosis.
Yeah. So let's bring that back to hypoxemia. This is the last time I'm going to say on this. I'm going to stop beating this horse to death. Is that it doesn't matter kind of like the reason why, but if someone has that low partial pressure of oxygen, their SpO2 is low. This is a long time thing. I love oxygen. I've been hooked on this stuff since day one, and I don't like going without it. I can hold my breath for like 3 seconds and I start freaking out. Now, if I have long-time hypoxemia, what do you think that means for my brain? What do you think that means for my heart?
Well, it's so much extra work.
It's so much extra work for both of them. And trust me, I don't like cardio. So if my heart has to pump more, it doesn't exactly enjoy this, okay? So a long-standing hypoxic event usually doesn't end well for your patient. So when you see these things, these tension pneumos, even these simple pneumos, if you're called to them, or these hemothoraces, other than your typical therapies that you're going to do, giving oxygen, putting your cheek on, oh, it wasn't the cheek, it was the glove, putting your glove on that sucking wound again, putting that 4-sided occlusive dressing, diesel therapy. Drive fast, get them within the jurisdiction, follow the guidelines, but you be safe out there always. But this person needs to see a doc. Like, we need to get these people into a state.
Yeah, they're not. They need somebody way above my pay grade.
100%, right? Exactly.
And if you get there and you're BLS, and even if you're really BLS, like brand new, like in Alberta, we have EMRs, emergency medical responders is the entry level. You don't have a lot of physiology, anatomy. You don't have basically, it's almost like, and I hate to use the word of, it's not advanced first aid.
No.
You're now a professional medical when you're medical professional.
You're a
medical
professional.
It's a little different, but most people need a hospital. right?
Yeah.
In the end, whether I'm an advanced care paramedic, I need most people, if they have a chest trauma, they have holes in it, they need a thoracic surgeon. They don't need Jason.
Yeah. Or Jason.
Yeah, or Jason.
Yeah.
And the biggest thing is get them in the truck and get them there.
Yeah.
So, couple things, just round things out.
Let's do it.
So we talked about pneumothoraxes.
Yeah. We had the simple.
We have
pneumo.
a simple pneumothorax,
Yeah.
which is just, it happens.
Yeah, exactly.
It's the tall, skinny guy usually.
Yeah.
Kinda, I won't say the word frail, but they're usually like thinner, tall.
Yep. Or pre-existing lung condition.
Yeah.
Right. We talked about that.
We also have the traumatic
Yeah. Which
pneumothorax.
makes sense. I had
Right.
trauma. I was in a car accident, whatever.
We put a hole in the lung.
Yep.
Air fills in that space.
You betcha.
The other thing we have
We
is
have an open or closed.
we have an
pneumo.
open or closed pneumo, which means we have the hole to the outside environment.
Yep.
Air can rush in because it's easier than to go in than going down through your trach and everything.
Yep.
And again, what it does, it collapses your lung, pushes stuff over. Hemo, blood. Usually will be closed. It could be open as well, right? If you get stabbed, I can get a hemo because you hit the right artery. It'll fill up that lung.
Yep.
And it doesn't necessarily mean it's going to leak out that way. It might just be easier to leak into the chest. So we got that.
And it's pushing up, and
So
that's the one that we don't want to keep putting the gauze on. We want to pull the gauze off and kind of let that blood drain out.
So again, a pneumothorax that has a hole.
Yeah.
We seal it up.
Foresight.
Protect it, keep the air from going in foreside. Again, if you look like you're having a tension pneumo, that's the one that's going to lead to death and not a good thing.
Yeah.
Again, if it's the open, you got the four sides of the occlusive dressing and pull it up. A lot of people I've seen, my job is I will show up to a stabbing where the guy's had a number of stab wounds to the chest, and you start taking, because it's just quicker versus losing a stem splint, you take off the tegaderms.
Oh, there you go.
Right? The
Yeah,
tegaderms,
get a
the
big
ones that
tag.
you go with that, you just keep sticking those on. And again, just be aware that after you stuck all those on, that if you do see a change and they're having increased shortness of breath, again, they might have some JVD backing up, then all of a sudden you can see some trail shift. And usually by that point, they're not really that nice. They're usually going to have more restlessness. They might lose consciousness because they're hypoxic, not getting blood to their head. So 2 types of pneumos: blood, air,
Yep, 100%. Yeah.
open and close. And in their end result, treat the signs and symptoms you find.
Yeah, exactly. Yeah, do what you can out there.
Take them back to the and get them to the hospital.
Yep, that's
If
where they
you're
want to be.
BLS, call ALS. Get some backup.
Yep, 100%. That's what they're there for. That's that's it. That's it. That's hemothorax. That's pneumothorax. And remember, guys, if you do, like Jay mentioned this, I want to say it one last time. If you do have that hemothorax, if we have to move the patient, we're going to put them on the side of where the injury is to make sure we're not squishing.
Yeah, because
the opposite.
You don't want to tip them. We don't want to be pushing the blood to the wrong side. So try to pull it to the one side. Anyways, that's it for me. I'm Jason Jolson.
I'm Jason Davis.
And we'll see you in the next one.